So hello everybody, today we are going to talk about the WHO Labor Care Guide in details and also compare it to the WHO modified partogram and see what are the differences in between the two and how is it that the WHO Labor Care Guide is superior to the WHO modified partograph. So let's get started. Now there are 7 sections that we had talked about in the previous video of the WHO Labor Care Guide. Now the first section, which is a very important section, includes the identification of the lady who's come to you in active labor, that is 5 centimeters or more of cervical dilatation. Now how do we identify that lady? Definitely her name is extremely important. We have to mention the name. Apart from that, her parity is important. Her onset of labor is important because we know that those patients who are in spontaneous labor are low risk, and those who've been induced into labor for some indication or the other definitely require a little more monitoring. So onset of labor is important, and risk factors and rupture of membrane. These two R's are very important. Why rupture of membrane, date and time is important? Because we have to be sure that it's not a prolonged rupture of membrane which can lead to maternal and fetal infections. So date and time of rupture of membrane is extremely important. Associated risk factors with this pregnancy, like for example, it could be a preterm labor, anemia, obstetric cholestasis, diabetes, whatever, preeclampsia, eclampsia, that is all to be mentioned in the risk factor section of the identification part. And last but not the least, we have to mention the date when the lady went into active labor. If she has been in labor in the same center, then we know the date of active labor. If she's been referred from some other center, then from the WHO partogram or the previous case sheets or the referral paper, whatever is available, from there we can note down the date when she went into active labor. So this is very important to identify the lady with these things. Now apart from these, the other informations which are available about the mother, like her blood group, her serology, etc., they have to be mentioned in the case sheet of the mother, but they are not specifically given a heading in the WHO Labor Care Guide identification section. Now it is important for students to kind of have an idea about the identification section, especially if you can remember the headings, so that if a question is being framed about these, which are the parts of the heading row, then you know what exactly they are talking about. But for people who are working in a labor room, you have the WHO Labor Care Guide with you. It has all the headings written there. You just need to fill it up correctly. So definitely it becomes a lot more easier for people. In fact, this leads to your tendency to make less mistakes and give you the chance to give a better handover to somebody who comes in your place to handle the labor, because this one sheet of paper can tell the person who's come about the risk factors, just this point, and you know that this lady has got preeclampsia, she's got diabetes, she's got whatever. Okay, so that is the reason the identifying portion is extremely important component of the WHO Labor Care Guide. Since it covers a very small section, that doesn't mean that you don't need to fill it up. Okay, so that is why I have been trying to impress upon its importance. Next, we come on to the time. Now this is very simple. Every column in the time section corresponds to 1 hour, and for those findings which have to be mentioned, for every 30 minutes in the first stage of labor, you have sub-columns. That is, for the fetal heart rate, you have a sub-column in this 1 hour column every 30 minutes. So fetal heart rate, you can plot every 30 minutes. Uterine contractions, you can plot every 30 minutes when the lady is in active first stage of labor. When she enters into the second stage of labor, again you have the 15 minutes sub-columns also. So it is not going to be a problem. Okay, just the broader columns are all 1 hour each. Okay, so when the lady comes to you, if she was 5 centimeters dilated at 6 a.m., then again you reassess. Most of the findings are reassessed after 1 hour and after 4 hours. So 6 a.m., then 7 a.m., then 8 a.m. Every hourly you can write the time, and you can correspondingly you can write the findings of the mother in that respective time. Okay, so that is very simple to understand. Just the thing which is to be remembered is every column corresponds to 1 hour of time. Now we come on to a very important section, as I was talking about supportive care, because I have felt while reading the WHO Labor Care Guide Manual that WHO is very emotionally particular about the supportive care, because it is the mother's right to have a companion of her choice, have adequate pain relief for a positive birth experience, because for most of the women, especially in high yield hospitals, pregnancy and delivery becomes a torture because of the pain and everything, and the level of uh, kind of sufferings they have to go through during that time because of the pain and because of the load in the labor room. It is a lady's right to have adequate pain relief, a good companion of her choice, and definitely the rest of the things we'll talk about. So the best way to remember the supportive care is the mnemonic COP, that is having a companion. Now, what are the findings that we have to write respectively according to the subcomponents of supportive care? What I'm trying to say is, if she has been given a companion, if you're talking about a companion with the mother, it is either a yes, that means she has a companion, either a no or a denial. Now, denial is something which is very common in a labor room, because a mother who's in active pain, she can deny almost everything in the world. Even if she knows it's going to be helpful for her and for the baby, she is definitely going to deny it. Most of the times because she doesn't understand the importance of it, and also many a times because she's in so much pain that she doesn't have the mindfulness to positively react to what is being told to her. So for that reason, if she denies, you have to tell her that you can have a companion of your choice. You are a good mother, we are doing it for your baby, please try to understand, take the companion of your choice. We don't have a problem with anybody, but please do have a companion. Okay, now as you can see, similarly it goes for pain relief. Either it's a yes, that means she has been given pain relief, either it's a no or she's denied because probably she's not understood. So if she denies, you have to explain it to her. What are the possibilities of pain relief? She could be given an epidural, she could be given a massage, she could be given meditation, she could be given medication. Whichever way it suits her, you can give her the options of pain relief, and then she can choose along with the companion. She can make a choice and you can give her pain relief accordingly. Similarly, oral fluid, yes, it has been given, no, it has not been given, and denial, that means she's not taking it. Many a times, women in labor, they want to eat, so they'll be like, I'll not drink water, give me something to eat. So if it's a low risk pregnancy, things are going fine, you can give her a light diet. Not in cases where you are expecting a C-section or an acute event, like suppose you're suspecting a meconium and you'll take her up for a cesarean. Don't give her a diet at that point of time. But we are mostly talking about cases where you're expecting a normal delivery and things are going fine. You have allowed the lady to have oral fluids. In those cases, you can give her a light diet as well. Now, what is this red color? This circle means the findings which we do not want. And these are the findings which are there in the alert column of every component of the WHO Labor Care Guide. Now, what does the alert component mean? That means something which should raise the alarm, put you on an alert, and something which is not desirable. So whenever you have something a finding in any of the sections which corresponds to the alert finding, it has to be encircled with a circle so that whosoever is just going through the WHO labor care guide knows that, oh, this was an alert point, and it will help you in making assessments in the assessment section and give her a plan. Like for example, if the supportive care says that she doesn't have a companion, then the assessment says she doesn't have a companion, that's an alert finding. So the plan would be give her a companion. Similarly, if the position is not what was desirable, it was something which was in the alert section, then the assessment would be it is not there, and the plan would be give her that particular thing. So these circles ensure that the alert findings are noted well and acted accordingly. Okay, so we've done with the COP, that is the COPP, companion oral fluid, pain relief, and yes, posture. Now posture cannot be yes, no, or denied. Okay. Posture, there has to be a posture. So it is either a mobile posture or a supine posture. We don't want a supine posture because we know if she's lying supine, she'll compress the IVC. The gravid uterus is going to compress the IVC. So in that case, we have to give her a choice that, see, you are a good mother. You have to understand if you sleep like this, the baby will be at risk. Even you will be at risk because the IVC will be compressed. You have to explain the companion. So you can take the position of your choice. You can squat, you can kneel, you can take a left lateral position, you can stand, you can walk. It is up to you, but please don't lie supine. So whenever it is supine, again you have to mention in the assessment, no, you don't want supine, so the plan is to change the position. So with every alert finding, you have an assessment and a plan ready in the lower parts of the partogram of the guide. I'll tell about it later. So this was the supportive care section. So we are done with the identification, the time, and the supportive care system. Next, we are talking about the baby, the mother, and the labor. Okay, so first we'll talk about the baby because the baby is the most important part of the labor room, isn't it? Everything that we are doing is mostly for the baby and so for the mother, but yes, baby is the most sensitive portion of the part of the labor room. So what are the findings that you have to mention about the baby? Of course, the fetal heart rate, decelerations if they are present, the amniotic fluid you have to mention, fetal head position, the occiput, whether it's anterior, posterior, or transverse, caput, and molding. So these are the things that you have to check about the baby. Now, when you are seeing the abdomen of the mother, what is it that you will see? The fetal heart rate and the deceleration. When you are doing a PV, what is it that you will see? The amniotic fluid, the fetal position, caput, and the molding. So this is on abdominal palpation and these are on per vaginal examination. Okay, so these are the parts of the baby assessment. Now, if we talk about the fetal heart rate, it is very, very important to check it at least for 1 minute. First half during a contraction, continue that for 30 seconds after the contraction is gone. It is very important to assess the fetal heart rate during the contraction. Okay, and what is the normal range for fetal heart rate? We all know it is 110 to 159. Now that value of 160, it comes in fetal tachycardia. Fetal heart rate, normal fetal heart rate is 110 to 159. So if we say 160, it is tachy. We have this tendency of remembering 110 to 160 is normal, 159 up to 159 is normal, 160 onwards it becomes tachy. Okay, so in the WHO labor care guide, there are a lot of less than, more than, equal to kind of things. So those who are working in labor rooms, they know it very well, but those who are trying to mug up a little bit of values, for them this is important that 160 is tachycardia. Normal fetal heart rate is 110 to 159. Anything less than 110 or more than 159 is the alert value. Clear, everybody? Now we talk about decelerations. Decelerations we know could either be absent or no, early, late or variable. Late or prolonged deceleration, a single prolonged deceleration is again alert, so it has been circled. And what are we going to do if this is present? We'll put the patient in left lateral position and do a prolonged auscultation, call the on-duty senior doctor. So while the time the doctor is coming, we are putting the patient in the favorable position and doing a prolonged auscultation, and then according to the findings we have to take a call what exactly needs to be done, what exactly is wrong, leading to the problem in the fetal heart rate. So that is all about fetal heart rate. Next abdominal finding about the baby, that is deceleration. Now no, that is done now. So the fetal heart rate and the deceleration, these are on the abdominal palpation, abdominal findings. Now the pervaginal findings, I think anybody who's done a PV knows what is amniotic fluid, amniotic membrane. So if the membrane is intact, we write an I for it. If it is ruptured and the liquor is clear, we write C. If there is meconium, we write M. M can either be light, moderate, or there can be thick meconium. So 3+ is thick meconium. This is an alert finding, so it is circled. Again, blood stained liquor, that is the abbreviated as B, that is again an alert finding and it has been circled. So the findings can be ICMB, that is intact, clear, meconium stained, as well as blood stained, but the alert findings are MB. Okay, and in M also it has to be 3+. Okay, so meconium 3+ or blood stained liquor. Blood stained liquor we know is important. It could be because of abruption or anything, so we have to be very, very cautious if you see blood in the liquor. Clear? Now coming on to fetal position, we know how a normal labor goes and we know how happy an obstetrician is if the fetal occiput is anterior. Labor progresses fine. So definitely anterior is going to be okay. Occiputo, posterior or transverse are the alert findings. Okay, so APT, apt can be the findings of which P and T are the alert findings. Okay, now when you're assessing these things, you have to do an aseptic PV and never during a contraction. If ever you have done a PV of a mother who is in contraction, I'm sure she will never forget the experience, nor will you, because women, they are extremely in pain during contraction. So just don't do a PV when she is in pain. After the contraction is gone, for a better assessment also you can assess the PV findings. Okay, next coming on to Caperton molding, it's very, very simple. Either it is 0, that is absent, or it is plus or triple plus. Again here like meconium, only similarly 3+ findings are the alert findings in these two columns, as is mentioned in the alert column of the guide. So that is what we have to discuss about the baby. Now we come to the mother. Now for the mother, we have to assess a lot of things, because if she is okay, then only we can expect the baby to be okay. So her vitals are very important. Okay, so we have to know the upper limit and again the lower limit of her vitals, the normal range of her vitals. So maternal pulse from 160 to 119 is normal. Systolic blood pressure 80 to 139 is normal. 140, we know 140/90 is the golden PIH value, we all know. So that is very well understood. 140 systolic and 90 diastolic onwards, it's abnormal. But the lower range of normal systolic blood pressure is 80. Okay, say, and for pulse it is 60. Temperature, now do remember this value 35. Okay, why I'm telling you temperature, the lower limit is 35, higher limit is 37 degrees centigrade. Contractions again 3, 5, 35. So 3 to 5 every 10 minutes is normal. So if you remember the value 35, you can remember two findings. Uterine contractions range, that is 3 to 5 every 10 minutes, is normal, and you can also remember the lower limit of temperature, which is 35. Duration of that we will come when we discuss about during the labor section. So for the mother, till now we have seen her normal range of vitals. Okay, anything which is not in this range is an alert finding, has to be circled, and you have to take the appropriate steps, tell the doctor on duty, senior doctor on duty, and assess and take a plan. Okay, now apart from these findings, we have another thing which is important, which I'm sure we've all done, that is a urine test. Now we have those dipsticks present in the labor room. A PIH patient, the moment she enters the labor room, check the urine protein. A dehydrated patient, when she comes, check the urine ketones. Especially for not active labor patients, but generally patients, obstetric patients in the first trimester, when they come with hyperemesis, we are very used to doing a urine ketone for those patients. So similarly, even when she is in active labor, you have to assess the urine protein and the acetonuria of that patient. Okay, now what are the values which are important in this case? Urine protein can either be absent, it can be trace, it can be +1, 2, 3. +2 onwards, whether it is a ketone or it is protein, +2 onwards, both are alert values. Okay, but for acetonuria, there is nothing called as a trace finding. It is either absent or it is +1, +2, +3 and +4. But for proteins, there is a trace value as well. So the values could be minus, trace, +1, 2, 3. So the highest range for proteinuria is 3+, whereas for ketones it is 4+. Okay, but alert values are the same for both, that is +2 onwards. Okay, so that I believe completes the woman or the mother section of the WHO labor care guide. Now we come on to the labor progress, the medication and shared decision making. Now these are easy sections where there is not much we have to do about it. Labor progress has again two components. First you have to see the uterine contractions, and then you have to assess how is the dilatation and descent. Okay, now uterine contractions, this was the range which I had told you. Contraction 3 to 5 every 10 minutes is normal. Anything low or more is abnormal or in the alert zone. Uterine contraction duration 20 to 60 seconds is considered to be normal. Anything less than or more than this range is again an alert finding. Okay, now you must be remembering that when you had this WHO modified partograph, we used to have these kind of findings during labeling of uterine contractions. These used to stand for mild, moderate and severe uterine contractions. That means intensity was being considered in the WHO modified partograph, but intensity is extremely subjective with a lot of interpersonal variations, so it has been removed now from the WHO labor care guide, and there are only two components of the contraction assessment, that is the number, that is the frequency every 10 minutes, and the duration. Frequency and time of each contraction is all that you have to remember. This is also over. Now coming on to the cervical dilatation. Cervical dilatation, we all know, we've always done this in the WHO partograph. It used to be marked with a cross. Similarly, we are marking it with a cross now also. But the concept of 1 centimeter per hour cervical dilatation is no more there, because it was found out that for every primi gravida dilating 1 centimeter per hour is too much of an expectation, that it is always not possible, can at times lead to unnecessary interventions. So we have this beautiful table in which it is clearly mentioned in what dilatation she can remain up to how much time. Suppose she's 5 centimeters dilatation, up to 6 hours she can be like that. If she's 6 centimeters dilated, up to 3 hours she can be like that. So so basically what I'm trying to say is the duration for which you can be with a particular dilatation is mentioned in the alert section. So anything which is less than the alert section is okay. The moment the lady reaches a finding which is in the alert section, you have to intervene. Okay, so that is a very easy way to plot the cervical dilatation. As you can see in this graph, a lady, she had come at 6 a.m. and she was 5 centimeters dilated. So 6 a.m. you put a cross at 5 centimeters. Then 4 hours later you've done a PV at 10 a.m. and she is now 8 centimeters dilated. So in the 10 a.m. section you put a cross in the 8 centimeter section. So this is actually that simple. Okay, just corresponding to the time you have to put the dilatation, and then you can assess the trend of dilatation. Similarly, the descent can also be assessed. Descent is it is a palpatory finding per abdominally done. You have to see how much of the head is palpable abdominally. Usually we divide it into 5 sections. So if 5 by 5 is palpable, that means the head is still up. It has not started going in. If so, slowly and slowly 4/5 will be palpable, then 3/5, then 2/5, and there will be a time when 0 out of 5 will be palpable. So similarly, you can see when the lady had come at 6 a.m. with 5 centimeters dilation, 4/5 of the head was palpable. So the descent is usually marked as a 0. So you mark a 0 when she comes at 6 a.m. and 4/5 of the head is palpable. 4 hours later you reassess and you see a little bit of descent has occurred, a little more, and 3/5 of the head is now palpable at 10 a.m. That means it has gone down further. So that is how we assess the head descent abdominally and cervical dilatation per vaginally, uterine contractions again abdominally. Okay, so this is how we assess the progress of labor. Now we have only 2 sections left: medication and shared decision making. Okay, now we were talking about differences in the WHO labor care guide and modified WHO partogram. As we see, supportive care is a new inclusion. It was not there in the previous WHO partogram. Uterine contraction intensity has been removed. This is again a change in the new guide. Labor progress, that the rate of progress of cervical dilatation at the rate of 1 centimeter per hour is again not there. Now evidence-based findings have been separately given for every centimeter dilatation of the cervix in the alert region. Similarly, shared decision making and findings for the separate finding charting for the second stage of labor. These are also 2 other differences of the WHO labor care guide from the modified WHO partograph. Shared decision making was not there in the previous partogram, and also a separate section for the second stage of labor was not there. But we are lucky now that for all these sections we have their corresponding findings to be plotted for the second stage of labor. Now we all know there will be a little bit of differences, like fetal heart rate has to be plotted every 15 minutes, uterine contractions every 15 minutes. But the funniest part is we cannot plot the cervical dilatation in the second stage because it's fully dilated when she has come into the second stage. So there is definitely no section for that part of the findings. Okay, so now we are left with only 2 sections. Let's quickly finish it up. Now, medication section. Okay, medication, either it could be a yes or a no. There's not much of findings which you can write. So either she's been given or she's not been given. If she has been given, then it is you have to mention for oxytocin the units per liters and drops per minute have to be mentioned when you are charting the medication as per the frequency told to you in the previous video. Medicines apart from oxytocin have a separate column. For them you have to mention, they have a separate row, and for them you have to mention the name, dose and the route of that medicine. For oxytocin it is units per liter, drops per medicine. Okay, drops per minute. And for the IV fluid that you give, it's either a yes or a no. You have to mention the IV fluid. Okay, so this is just what you are giving. You have to write it down. Last but not the least, a very important section, because this is something you do because you have to keep the mother involved with the labor. She should know how much time she's been in labor, how much time she's going to take to deliver, what is being done to her, and she has an opinion about what is being done to her, what she is wanting out of the labor process, or if she has a suggestion to make, you have to give it a hearing. Okay, so to hear that, you have to explain things to her, also to her companion, and that is what is a shared decision making. Okay, now that has two components, an assessment and a plan. So you talk to her, explain it to her, like for example that there is no pain, there's no pain relief which has been given to the mother. So you talk to her and to the companion that, see, it's good if we give you some pain relief, things are going to be better. She'll understand you have a shared opinion about this pain relief, and now according to her choice you can give her a pain relief. So the assessment would be she requires a pain relief, and after a shared decision making you give her a plan, offer her a plan according to her choice. Like suppose if I am the mother and you come and ask me, ma'am, my assessment is you require pain relief, and now you want my opinion about the kind of pain relief I would want, I would say give me an epidural. So then the plan would be a shared plan after consulting the mother, that we have decided for a epidural. So this is the best way to understand this section of shared decision making according to the findings in the alert zone. Findings coinciding with the alert zone, you have to act, assess, and then act after discussing the assessment with the mother. This is what is the meaning of assessment and plan. Plan is always after you have shared the assessment with the mother, and then you come to a plan. So this is very, very simple, the easiest example I told you. And if everything is going well, you just have to see the assessment is normal progress, and the plan every 2 hourly you have to write the plan, every hourly you have to write the assessment. So 2 hourly, if everything is okay, you say continue as it is, continue the routine monitoring of labor. That is going to be the plan. If at a point you feel that there is need for ARM, the plan would be ARM. So need for ARM is the assessment and plan is ARM. So that is what I'm trying to say. Anything which you find is not going according to the expected flow, you make an assessment about it, discuss it with the mother, and then put a plan for it. So this is very, very simple to understand. And the same, all the 7 sections, they have to be followed in the second stage as well, except for minor changes. That is the frequency at which you have to monitor the fetal heart rate, uterine contractions, and for them a 15-minute sub-column is there in the second stage of labor. Now a few more things which I would want to discuss is after we've done about understanding the WHO labor care guide and how it works, there are few things, clinical things I would want to discuss, so that we know that what we are striving for. We are working so hard behind the WHO labor care guide to give the mother a positive birth experience, to prevent unnecessary interventions, to give her optimum health to the mother, to the baby, so that everything goes well about the labor, isn't it? So, what is it that can go wrong if we have findings coinciding with the alert findings? Now, suppose if you see that in the woman section, like for the baby and everything, we've already discussed, especially for the mother, why is it that her vitals, her urine protein, her urine acetonuria, why is it so important? Suppose if the mother has proteinuria, so 2 plus proteinuria, it is an alert finding. Why is it important? Because we all know it can be associated with preeclampsia. It could be because of some UTI which was there, and that can suddenly strike the bell that, oh, this is because of the UTI and not for anything else. It could be because of severe anemia or an undiagnosed kidney disease or a heart disease. So something which was undiagnosed till now, suddenly a proteinuria pops up and you have a diagnosis. So it is actually that important. Similarly, acetonuria can be there in dehydration and prolonged labor. We've seen how dehydration leads to acetonuria, especially for women who have hyperemesis. Not in this scenario, but hyperemesis patients, they have acetonuria. So that is why acetonuria is important in cases of dehydration, prolonged labor, and undiagnosed diabetes mellitus. I have had a bad experience about this. A lady, she came up and then she ended up in DKA and acid and so many things. And then when she had respiratory distress, we just checked her CBG and came to know that she was in frank diabetes, and she didn't know. She was a unbooked, uninvestigated patient. She just came to us in active labor, and we had to take her up and somehow save the mother and the baby. So acetonuria can give you a lot of information and can diagnose some undiagnosed problems as well. Now, maternal pulse, why is it so important? Again, in fever, you can, suppose you've not touched the patient for some reason, you have not been able to assess that she is having temperature. Suddenly, you've checked the pulse and you see she's tacky. Now, you check the temperature and you see, oh my God, she's got fever. So, sometimes fever can be diagnosed. She could be in shock, she could be bleeding. Some maybe there's a rupture uterus. So many things can happen. There is a bleeding PV, which you will notice once you see that the pulse is going high. It could be a shock. In all these cases, there is a possibility of having tachycardia, especially initially. Drop in maternal pulse could be you've used a drug and now it is affecting the pulse of the mother. Okay, anything in labor, you've used some medication which can lead to decrease in maternal pulse. So now you know that this bradycardia is not for anything, but it's because of the drug that was given. Or it could be a undiagnosed heart disease. It could be because of immense pain, bleeding, or if she is supine. So if she's supine, you can just tell her, you just change the position, things will get better, because it's mostly because of the IVC compression. But apart from that, undiagnosed heart diseases, pain and bleeding, these are extremely important, especially bleeding and heart diseases. When they lead to maternal bradycardia, that is something you have to be very worried about, because a lady who's in active labor, she's bleeding and profusely and she's having a heart disease, that is not a good finding. Okay, bradycardia means she's actually bled pretty much. Similarly, fall in the systolic blood pressure of the mother. Again, that could be, these alert findings could be because of bleeding, or she is in shock, hemorrhagic or septic. Anything can lead to a fall in systolic blood pressure. Rise in systolic blood pressure, rise in diastolic pressure, I think you can tell me better. It can happen in preeclampsia, eclampsia, PIH. So this is something we are very used to, and I don't think I need to explain much about, but these findings, please have a note of it, not only for exam purposes, in your clinical practice, especially undiagnosed heart diseases, kidney diseases, diabetes. Many a times, just by these simple assessments, you can diagnose them and save the mother's and the baby's life. So that is all from my side about the WHO Labor Care Guide. If you have any questions, you can mention in the comment section. Thank you.